Welcome back. Before the break, Dr. Weiler and the PCDT shared our starting point for this public meeting and some of the questions we want to explore. And now I'm very excited to kick off our first panel discussion. At this time, I ask our panelists to go ahead and turn on video if you haven't done so already. And we're very fortunate as well to have two presenters in person today. In this session, we have invited 4 esteemed experts to discuss how they develop objectives for performance measurement for total cost of care models. After each panelist offers a brief overview of their work, I'll ask a few questions, and then PTAC members will have an opportunity to ask any follow-up questions. The full biographies of our panelists can be found online, along with many other materials for today's meeting. I'll briefly introduce each of our guests and give them a few minutes each to introduce themselves. After all 4 introductions, we'll have plenty of time to ask questions and engage in what we hope will be a robust discussion. So first, we have Dr. Cheryl Damberg, who is the Director of RAND Center of Excellence on Health System Performance. Cheryl, welcome, and please go ahead.
All right, thank you for having me. It's a pleasure to be here, and I can't actually see everybody in the room, but let me start by just giving you a very brief overview of some of my background that's relevant to the discussion today. So over my career, I've been engaged in performance measurement, and I was actually thinking about this last night, that this started back with one of my very first jobs at HHS, working on the Healthy People Objectives for the Nation, and looking at measurement of performance of the health system writ large. But I have spent time working with purchasers. I used to work for the Pacific Business Group on Health, now the Purchasers Business Group on Health, leading efforts to do performance measurement and shift to value-based payments, getting the private sector to pivot in that direction. I have also had decades of experience developing and applying these performance measures in practice, and so understand the complexities of development of measures as well as their implementation. More recently, I've been involved in a range of studies looking at trying to understand the impacts of use of measures and financially incentivizing providers for their performance. I've also been trying to understand their response to performance-based accountability, particularly in the context of total cost of care models, and understanding what they're doing to bend the cost curve as well as maintain or improve their performance. Lastly, more recently, I've been exploring the challenges that providers face in redesigning care to get to high performance. So next slide. So we were asked to consider a few questions for today's panel meeting. And, as I think about performance measurement and using performance measures to drive delivery system transformation, I think we have to be clear on what are our key objectives. And I don't think it's just to measure performance. I think what the objective here, in my mind, is that we would encourage systems that are caring for our population to build a measurement infrastructure so that they internally can monitor and improve their performance, and in the process change care delivery through an ongoing learning process. And I think the measurement that we collectively use, whether it's private sector payers or public sector payers, it provides a really strong signal about where these organizations should invest resources related to transformation activities. So I think we have to sort of carefully think about where we want them to invest. Also, I think there's sort of this tension in play between what I'm going to call macro level measurement versus micro level measurement. So one can sort of go into the weeds, measure lots of things versus measuring sort of broader constructs and allowing health systems to dig deeper to try to understand what are some of the drivers. And I think the total cost of care measure is one good example of that. And I think if we stay focused on some of these macro measures, they may be sufficient to drive transformation and be less burdensome to systems and providers. In terms of the types of incentives that are needed to facilitate improved outcomes, I think one thing to consider in any performance measurement dashboard is the need to have a broad set of measures to cover the range of quality dimensions that are in play, but also importantly to avoid gaming. When there's a small number of measures that focus on a narrow set of things, this can create an environment that allows providers to game and focus on a very narrow set of things. And, we would lack understanding of what's happening in a broader sense related to the quality environment. I think we also need to be emphasizing more health equity measures. We see time and again the lagging of performance among certain subgroups of the population. And I think we need to do more to tie performance measurement and payment and accountability to trying to do better with these subgroups. Importantly, we need to be doing more to measure patient-reported outcomes and using that information to change how we deliver care to patients. And most importantly, and if you want to shift to the next slide, this point is made on the second slide. I think the critical thing here is that measurement is only one piece of a larger puzzle, and that other strategies and tools are needed to actually drive system change. And I would say, first and foremost, some of the what I've been learning from my work in interviewing health systems and provider groups around the country is that payment reform is happening too slowly for them to actually invest in transformation. When you ask them what percent's at risk, generally they tell me a very small percentage, 1-2% of their total revenue flow. And I think they had expectations that there would be more rapid transformation to these models, and it's been slow going, at least from their perspective. And the payment reform is really needed to support this care redesign and innovation. And another thing is, changing up how we design insurance to drive value. So there are a number of things that should be considered in concert with performance measurement. Some of the issues on the table, so I sort of listened in a little bit toward the end of the last one. This issue of burden comes up repeatedly about, do we have too many or too few measures? So this is where I think we have to be judicious and thinking about what are the important areas to measure and what can provide some of these macro signals. I do think that outcomes are very important and something we should focus on, but we have to recognize they can be harder to measure, either because they require more clinical detail, they take longer to observe, potentially they require collecting data directly from patients, but I would say we need to do more to push to better measure in that space. I may be a different voice in the room. I still think it's important to measure these various processes of care. Certainly many of them are tied to evidence-based outcomes. And in some prior work that we did around the hospital value-based purchasing program for CMS, we actually did find improvement in outcomes. And I think one needs to be careful reviewing the literature on the relationship between process and outcomes, because many of those studies have significant flaws that don't actually tell you what's happening. And I can say more about that later. So I've touched on disparities in patient experience, but one thing, and I'm hoping Eric is going to touch on this, we've had outdated processes for performance measurement, construction, and reporting. And, I think we're at this critical juncture where we can do better And this will enable a broader set of measurement, leveraging, the electronic health record, AI tools, and so on. So I think we're at this, pivotal point where the landscape may change significantly around performance measurement. And then lastly, I would note that, there's this tension between measuring at like the organization level versus the individual physician level. But a lot of the actions that need to take place to actually improve performance are not sort of right at the front line with the individual physician. And in my conversations with organizations who are trying to drive system change, a lot of that change happens at the organization level. So I think we need to be mindful of where we're targeting these various incentives and what type of behavior we're trying to change. So I'll just stop there, and I think you're moving on to Helen next.
Thank you so much, Dr. Damberg. We're really interested in hearing your insights in the questions period as well. Next, we have Dr. Helen Burstin, who is the Chief Executive Officer of Council of Medical Specialty Societies. Please go ahead.
Great. Thank you so much for having me today. It was really a pleasure to hear the earlier presentation by Dr. Weiler and the team. So many of the reflections were things Eric and I were noting. We could have easily jotted down many of the same things, but thank you for the detailed analysis. It was, I think, as you'll hear, reflected in a lot of our comments as well. So as mentioned, I am the Chief Executive Officer of the Council of Medical Specialty Societies, which is really an organization of organizations. We work to advance the expertise and the collective voice of specialty societies, really in support of physicians and the patients they serve. Very importantly, that last part is quite intentional in our mission. We currently represent 53 specialty society members across medicine, primary care to surgery and everything in between. So very importantly, this isn't just a reflection of subspecialty medicine, but just broadly understanding it from the physician specialty perspective. Collectively, those organizations represent more than 800,000 individual physician members and other clinicians as well. Specialty societies, and we've talked a little bit about the burden already today, play a significant role in both the development and the testing of quality measures. And I'd like just to come back to the testing issue, which is a huge pain point on the path to implementation. There are currently really no dollars out there except for some foundation support for quality measurement. These are not inexpensive measures to build, as you've heard. The idea of spending $500,000 on a measure and then a several-year process ahead of you to get it through approval and finally getting it into practice is a difficult and heavy lift. About 20 of our societies have clinical registries, some of them have multiple. For example, ACC and the American College of Surgeons each have multiple clinical registries. We've seen a significant change over the last several years. There's really a move towards using much more information that emerges from digital sources as well as electronic health records, even practice management systems. It is still a very heavy lift, and most of the societies still rely on data folks who really help with data intermediaries, which are expensive, difficult, and costly. So that translation piece continues to be significantly difficult. Just about myself, I have a very long history in quality and equity measurement. I was the former chief scientific officer for a decade at the National Quality Forum in the past. I'll also mention, just interesting being in this room, it is 20 years since I led the first National Healthcare Disparities Report at the Agency for Healthcare Research and Quality. I think we all thought putting out those data stratified by race and ethnicity would change everything. And very sadly, very little has changed in both equity measurement, assessment, and improvement. It's hard to not be in this room and reflect on, we actually did the launch right in this room 20 years ago. So with that, let's go to my next slide, please. I just have one slide of key takeaways. We'll have lots of time for discussion. I think very importantly, as we think about the role of physicians in this space, and I say specialists really broadly here, both primary care as well as specialty providers, specialists in general, we have to be accountable for measures that likely are attributable to our performance. But as we really think about these population-based total cost of care models, really important that even if you're not directly attributable, thinking through what your role is in terms of how that's reflected in the team-based population health measures, I think is going to be critical. For example, looking through some of the other lists of measures of access and timeliness directly makes sense for you to think about it through the lens of what a specialist might bring to a population-based measure, for example. And I think as we think about what's next and the kind of measures that we need, specialty measures that reflect appropriateness, shared decision-making, and patient-reported measures, I think are particularly, they're difficult, but I think they're also the ones that potentially support collaboration across time, across settings, across clinicians, in population-based total cost of care models. And so I think hopefully there are opportunities for us to think about how to take, for example, many of the clinical guidelines and appropriateness criteria that are already embedded in the work of our specialty sites and think about how they actually can become part of these models going forward. I think there are some interesting collaborative strategies there. We have to think about the strategies to include specialty-specific measures that derive from rich clinical data, particularly in clinical registries, as well as digital quality measures, digital quality measures, but really, really importantly, developed for and by clinicians. Clinicians really looking and reflecting on, if it's difficult to collect or it's important to collect, is the juice worth the squeeze? Is this a measure that I'm going to want to look at, turn to my colleague on the right side of me, the left side of me, and say, how did you do? Because actually that measure is meaningful enough that I want to look at it and see how I can improve performance. And unfortunately, a lot of the claims-based measures we have currently don't answer that, would not pass that test. They are things we just sort of look at, and it's difficult to really assess what it means clinically in terms of my role, in terms of quality improvement and clinical improvement from the perspective of the physicians. And then finally, I think very importantly, and this came out significantly in Dr. Weiler's performance, the idea that we have measures that are meaningful to physicians, and I would add here, and patients, and that provide actionable information that can be used to drive improvement across patient-focused episodes is where we need to go. Those are difficult to do. I know several of our studies are currently developing new measures in that space, but again, the time crunch, the lack of test beds for testing measures, the difficulty of getting them into implementation, the continued difficulty of really creating digital quality measures given where we are right now is still a leap. And so anything I think we can collectively think about what we can do coordinated way across our different sectors is where we need to go right now. The current status quo is not acceptable. It doesn't work for anyone, as I think you elegantly pointed out in your presentation, Dr. Weiler, and by your team. And it's really time to think differently. And hopefully this is an opportunity. So thank you.
Thank you so much, Dr. Burstin. Really looking forward to hearing your perspective through that 20-year lens of working on change in this area. So next we have Dr. John Bulger. He is the Chief Medical Officer of Insurance Operations and Strategic Partnerships at Geisinger Health Plan. Please go ahead, Dr. Bulger.
Great, thank you. So, as you said, my name's John Bulger. I'm that mouthful of a title, and I bring a number of different perspectives today. It's really appreciate the opportunity to talk and thank the committee for that. And it's great to do this with Cheryl and Helen and Eric, and I think we'll have a rich discussion. So my primary role now is as Chief Medical Officer at Geisinger Health Plan. And if you don't know about Geisinger is in Pennsylvania. It's in north central Pennsylvania. And I included the map just to give some flavor of where our clinical footprint is, which is the blue area. From a health plan perspective, we're statewide in Pennsylvania in Medicaid, and that's about half of our business. And then we also have a 100,000 members in Medicare Advantage, and then have commercial, both ACA and non-ACA commercial plans. So it's really across all lines of business. It's about 600,000 members, government and non-government programs. So I have that perspective. I also play a role, and that's part of the long title, within our clinical enterprise, and I help lead our ACO. So work with performance measurement and quality measures a lot in what we're reporting in many of with the ACO and several other CMS demonstration projects, total cost of care projects. I used to be, prior to going to our health plan, I've been at Geisinger 26 years. I was the Chief Quality Officer at Geisinger, and in that role was primarily responsible for all the quality reporting that Geisinger did, both inpatient and outpatient, and did a lot of work around quality measurement. And most recently, as I had there, I was a former chair of the NQF's CSAC, which is the committee at NQF at the time that all the measurement reviews came up through, and spent a number of years on that and a number of years on many of the subject matter committees as chair of the readmissions committee. So I come at this with really a number of different viewpoints as to where we are. Next slide. And I don't want to take up a lot of time, so I somewhat cheekily maybe I said, the first takeaway I have is keep it simple, and that's why I tried to keep the slides simple. But I think we heard already today at the amount of time that providers put into this, and I can say from wearing my health plan hat in talking to providers, anything you need more than a few minutes to try to explain to them, and certainly if you need a couple-hour meeting or you need a book of a document to give them to try to explain whatever the program happens to be, whether it's a P4P program or whether it's how you're doing your value-based program and what the measurement is, you pretty much lost them after the first few paragraphs or after the first 5 minutes. So keeping it simple, I think, is the most important thing. I think there is a need to focus on outcomes. I think where we have good data that ties process to outcomes, I think it makes sense to use that process, but it's the outcomes that matter. And when we're looking at what we want people to report, we really do want to focus on the outcomes. I think equity is important, and Helen just talked about that. I think it helps us when we're measuring to measure in many different ways. So you want to make sure that the denominators, and this is where sometimes it goes against the keeping it simple, but where the denominators include the groups that you want to make sure that you're not missing from an equity standpoint. And it's one of those areas where I do believe, and I'll talk about it in a second, that if you aren't measuring that, it won't be managed. And lastly, I think the goal of measurement in total cost of care programs is to protect the public. And in my days at NQF, we talked a lot about the use of measures. And I think the use becomes very important. So the question is, are you using them for reporting, or are you using them for improvement, or are you using them for accountability, or are you using them for payment? And I think what you're using the measures for means a lot to physicians, a lot to other providers, and changes the way those measures are used. So if they're being used for payment, it's a much different story than if they're being used for improvement. Now, sometimes we like to think that we're using them for both, but I think we need to understand when it changes the payment, it changes the way providers look at those measures. And I think there's a danger when you do that, because you end up essentially studying for the test. So providers figure out how to do well in the measures, and that may or may not play a role in whether patients are getting quality and equitable care. So I think in total cost of care programs, you've already set up the program from a total cost of care standpoint. And in almost every case, if you do a good job from a total cost of care standpoint, you will have high quality care. What you're looking for, I think, when you're measuring that then, is to protect either areas of the public that are underrepresented, or the public in general, to make sure that you don't end up with gaming the system and not studying for the test piece. And, I'll end just to say, many people attribute to Deming the notion that he said you can't manage what you can't measure, which he actually didn't say. That one of the things he did say was one of the 7 deadly sins, or 7 deadly diseases of management, is running a company on visible figures alone. And I think I like to, there's a statue outside of the National Academies of Science of Einstein, and I think he puts that well. It says not everything that can be counted counts, and not everything that counts can be measured. I think the goal is to try to bring those together. And that's why, for me, total cost of care programs make so much sense. Because, again, I really do believe that doing the right thing for the patient is, in the long run, almost always the lowest cost. And then you need to wrap things around it to make sure, again, that the system is one that's true and isn't gamed. So, again, I thank for the opportunity to talk today and looking forward to the discussion.
Thank you so much, Dr. Bulger. Really appreciate the focus on simple clarity and looking forward to hearing your perspective from the diverse roles that you've had. So finally, we have Dr. Eric Schneider, who is the Executive Vice President of Quality Measurement and Research at the National Committee for Quality Assurance, and also a previous submitter of the Medical Neighborhood Advanced Alternative Payment Model proposal. Please go ahead, Dr. Schneider.
Great. Thank you very much. And thank you to the committee for the opportunity to be here today. It's really a pleasure. And thank you, Dr. Weiler, for what I think could be a really useful reference for this current state of where we are. It actually is way more detailed than anything I've seen. So it's wonderful to have that resource available to us. So I'm coming today, nearly 30 years ago. I was a fellow at NCQA for 1 year and did a project with NCQA on the digital future of performance measurement. So why were we doing that in the 1990s when the internet was barely a thing, the web browser had just been invented, and cell phones were still flip phones? It was because we realized right away, as we were starting to develop quality measures based on health plan claims data as part of a response to the HMO movement, that was not going to be a sustainable model, that claims alone were not going to get us the data we needed to accurately measure quality in a way that would be useful to providers providing care at the front lines. And I speak as a primary care physician who practiced and taught primary care for 25 years. We wrote a report at that time on the digital future of performance measurement and published a paper on the health information framework and what were the 7 features needed. And I decided that that wasn't going to happen in my lifetime because none of the features that we really needed, health data standards, health data infrastructure, really existed, or I thought could exist in my lifetime. The good news is I'm here to talk about this still, and I think 7 of those features now do exist. So if we go to the next slide, I'll talk a little bit about NCQA and its mission. Our goal is to improve the quality of care. We're a nonprofit. And we do that through measuring health outcomes, clinical quality, and patient experience, promulgating standard measures. We accredit health plans and accountable care organizations increasingly, and we recognize physician practices and some specialized care models. And I would say our model also is sort of needing an upgrade to reach into the digital future, and I'll say a little bit more about that in a moment. But if we go to the next slide, the durability of HEDIS, the health effectiveness data and information set, I always trip on that because it used to be the health employer data and information set, but it's healthcare effectiveness, is a set of 70 plus measures that health insurance plans use to measure and report on quality. It's widely used. As you can see here, 203 million Americans are enrolled in populations that report quality using HEDIS. That's 60% of the population. And it constitutes 70% of the measures that CMS put into the Universal Foundation when it looked across the agencies and the programs and said, what's a core set that's really vital and important? And this speaks to John Bulger's point about keep it simple, keep it focused, and Cheryl's point about macro signals and how to manage those. I think, interestingly, the discussion about population-based total cost of care goes back to what we were thinking about in the HMO era, the 1990s, that the idea of a population-based approach is that there's an accountable entity that's responsible for a membership or a population. The way that population can get defined differs across settings. But I think one of the points we probably, or I hope the committee will focus on, is sort of what is that? What is the implication of that? Because the origin of HEDIS actually was in that sort of insight that a population-based total cost of care approach actually imposes a budgetary constraint that doesn't exist usually in the system. And that creates downward pressure on spending and the concern that quality will be eroded as a result of that. The theory we have is that by imposing that financial risk, we actually motivate, that's tied to the clinical risk that exists, that healthy populations will actually cost less. And so we want to see an increasing health of the population as a way of reducing the costs. And this creates the right incentive. This mechanism creates the incentive for that. But the big worry, and I think we've seen this play out to some degree, is that the reverse occurs, that the financial risk becomes the central focus, that the stinting on delivery happens, that people get excluded, members get excluded from care, and we end up with worse health outcomes. And I say that because during my time at the Commonwealth Fund, prior to coming back to NCQA 2 years ago, two facts sort of became very apparent to me, especially comparing the US to other high-income countries. The first is that there's strong evidence that our poor health outcomes in the US are tied to inequity in the way we deliver care. And the second is that the cost burden on patients and families, or the way we're currently organizing our payment systems, is eroding trust among people, and that impedes their timely access to care, and it results in delayed diagnosis and worse outcomes than might have been possible otherwise. So that's a bit of a wind-up to a question which I struggled with, actually, as I was thinking about this presentation, is what should we require as sort of the minimum entry criteria for an organization that would take on population-based total cost of care payments, or a payment model? And I think two things for sure. There are probably a longer list, but one is this notion of impaneled or attributable members, not attributed to, but where the organization really is responsible for the population, whether they're in the office or not in the office. So empanelment. And then second is, and others have spoken to this, the ability to integrate care across the continuum. And I think you've identified that as an important. We currently still have a system of primary care operating independently of specialty care, operating independently of behavioral health, operating independently of the community-based organizations who can provide for the health-related social needs of the population. And that really has been kind of vexing us for some time. So if we go to the next slide. As I thought about that and that perspective, I thought, what are the most important things that differentiate a population-based total cost of care model from any other approach that one might design in performance measurement? And these are pretty much in priority order. If we really want to improve health outcomes, equity probably has to be the first consideration. I know in the model it's there, but it's sort of one of the attributes of quality. And I've been persuaded by the data and the comparisons that I've been involved in that that disparities and unmet social needs, reducing disparities and addressing unmet social needs are really vital if we want to see progress. And a total cost of care model, whether it's to an insurer or to an ACO or to another organization that's bearing that risk, really should be very laser focused on those objectives. In the HEDIS set, we have pioneered, I guess, we're at first year experience of stratifying the HEDIS measures by race, ethnicity, and we'll be sharing more on that as the year goes by. We also have introduced a social needs screening and intervention measure, which I know CMS has a similar version of. But we really tried to emphasize the intervention part of that it's not enough to just screen, it actually is important to intervene. Closely related is the access to care, and Helen mentioned the availability and timeliness. It's come up in other contexts. But what does it mean to measure that type of access? So access to specialty care is a particular challenge right now. Some simple measures, they seem simple, but we've been trying to implement them for 20 years and we can't because of our data systems. But following up after an abnormal test result which seems like one of the most basic functions of a functioning healthcare system, is still, we've had several runs at this over 20 years at NCQA, and it continues to be extremely challenging to implement. Measuring delayed diagnosis is another area that can get at the access issue. On experience, so I'm going to experience because of this trust, this erosion of trust problem. And so in a total cost of care model, the consumer, the patient, the family is extremely sensitive to the idea that rationing is occurring under that model. So there need to be measures to address that experience. And in particular, something we've never tackled well is the care of people with multiple chronic conditions or complex care needs. And we've been working for about a decade on a person-centered outcomes measure, which a different approach, really. We described in a paper we published in 2014, I think it was, that there's the guideline-based, evidence-based care model, but then there are the things that primary care doctors are trying to do with their patients to achieve goals, life goals that a patient may have. And it is possible to document those goals. We've actually demonstrated that in some of our pilot work. It's possible to document those goals to measure progress toward those goals between clinicians and patients. And I think that innovating to try different approaches is going to be vital if we want to do total cost of care type measures. And then finally, in the clinical effectiveness, we're really, I think, sort of on the precipice of having the health data ecosystem that I described earlier on that could support better clinical data to support more meaningful measures. And the health data exchange standards that the Office of the National Coordinator has been putting into regulation of EHRs, the info blocking regulations that are sort of trying to create an environment where health data exchange can occur, and our ability to digitally specify, deliver, and report measures is something that NCQA is actively working on right now. But again, I think it has to, and actually safety and reliability is another area that we've just not done a good job of measuring. Again, that probably comes back to the idea of following up after abnormal test results, the kind of basic business processes that create safe and reliable care. We don't have great measures of that. But again, the technologies, I think, are getting there. So I guess I'll conclude by saying that we kind of thought we could fake it on claims data for 30 years. We can't. I mean, we can get only so far in a claims data environment. We really do need to make investments in the health data infrastructure that could create the clinically relevant measures, usable at the front lines, usable by population health managers, and could support many of the objectives, I think, that you pointed out. I do think we have some opportunity to innovate on person-centered measures. And then finally, I agree with the other panelists, and maybe we've all been agreeing about everything, which we didn't coordinate this, so it's kind of interesting that we could come to many of the same conclusions, that measures that incentivize care coordination and team care are really probably vital if we're going to succeed going forward in a total cost of care framework. Thank you.
Thank you so much, Dr. Schneider. Your experience and background also rounds us out in a very interesting way. Really looking forward to the dialogue. So next we're going to move to some core questions, and I just want to alert the committee. There will be a section for you to ask the panelists questions as well. So start thinking of those. If you do have a question when we get to that section, please tilt your name tag up so I'm aware of that. But first, we're going to start with some core questions for the group. And in the interest of ensuring balance across the different perspectives and questions, I want to encourage the panelists to keep your response to a few minutes, and I'll call on you in order to answer each of the questions. So our first core question is, what are the main goals of performance measurement for total cost of care organizations? For example, to drive change through financial incentives, to provide actionable information for providers, or to inform beneficiary choices. Let's start with Eric Schneider.
Sure. Well, I think I touched on some of this in my opening remarks. And I do think that coming back to the total cost of care, we have imagined that the same measure could be usable at various different levels of the system. And I think that in this context, really focusing on the organization level, we're front loading a lot of this, or offloading a lot of the work and labor to produce this and respond to it to individual clinicians or small teams or small practices. And that's just really not in a financial risk model. You can't put that risk on the individual providers in the same way that you can on a larger organization with a larger population where they can manage both the financial and the clinical risk. What we're missing, I think, in that context is, again, the nuanced data necessary to really understand the risk and the health needs of the population beyond all the insights that people can gain in a small practice or in direct clinical care. We see some amazing practices out there, primary care practices and federally qualified health centers and other organizations that are doing tremendous work, but they're operating without a kind of network around them and a network of support. So I think that's one of the, I hope that was responsive to the question.
Excellent. Helen.
Yeah, I think we're going to be all building on each other's comments. For sure, I agree with everything Eric has said. I will just add that I think some of this really comes down to, and Angela and I co-led a webinar recently with the state innovation folks, and it was really interesting how this concept of what a provider is, this keeps talking about providers, is really unclear, and it's really different. And I think when you're really talking about physician-based payment, or I want to broaden that because I think the reality of clinical practice, it's not all doctors. This is really about clinical care. Healthcare professionals' performance versus the provider's performance, if we're thinking about a system, are often very different. I think we really have to think thoughtfully at these population-based total cost of care models to really think about what everyone's role is in that broader model. And what is the responsibility of the clinical care team? How do you integrate within the broader vision of, for example, what you're reporting at the system level back to the group? So I think thinking about measures then that get at some of that clinical effectiveness work that Eric mentioned at the bottom of his list, those still can be directly relevant if we can get to really important clinically relevant measures. For example, American College of Rheumatology, one of our members is developing a measure looking at patients with RA and their number of symptoms and joints affected, right? Very logical, connect that to treatment. We've got a grant program currently with some of our registries developing diagnostic feedback measurement. Something really clinically relevant would be incredibly important to a system because it really crosses what needs to happen from a patient's perspective in terms of access and timeliness as well. So I think very much thinking about getting to measures that reflect, I think what's listed out here in that question, actionable performance, and then thinking about at what level you're considering those. Actionable performance for your clinical care team may be very different than actionable performance at the system level. And I think we need to keep those connected but separate, because I think the measures that drive those may in fact be different. Thanks.
So helpful. Cheryl, let's go to you next.
All right. So Helen just stole some of my thunder because I agree with her related to sort of actionable for who and, what type of measure best serves their ability to take action. I think that the primary goal for performance measurement is it's really to produce information for driving change within a health system, such that you can produce, better care for patients and help them achieve better outcomes. And, I think one of the challenges that happens in this space is that we're trying to do multiple things for multiple stakeholders. And at the end of the day, while I was one of the early parties to produce public report cards on performance for consumers, I think that space, continues to remain challenging to produce the kind of information that consumers can actually use to make choices, whether it's around choosing providers who are lower cost for the same type of service, same quality of service, or, finding organizations and providers who deliver better care. I think that space continues to challenge us. But fundamentally, I think what we're trying to do is we want all providers in the space to be A-level providers. And so I see this as information to raise all boats. We use financial incentives to try to, garner the attention of the system. But at the end of the day, my objective for performance measurement would be to help providers have information to understand how they're doing, where they can improve. And then, they as a community can determine within the confines of their constraints, their abilities, and the resources they can bring to bear, how to drive improvements.
Thank you. And John, let's go next to you.
It's a tough group to go last in. I was actually writing down "rising tide lifts all boats" right when Cheryl said it. So and I do think that's a good way to characterize it. I just break this up quickly. That I think from an accountability standpoint, in total cost of care organizations, we started to look at it more from a gating mechanism. And again, this is at accountability, and I think I would agree with what Eric said from at the organizational level, where you're trying to look at measures, some of those processes that lead to outcomes, some of those outcomes, and I do think, as was said earlier by Cheryl, is you have a kind of balanced portfolio of those measures, but they're a gate, if you will. So they're, as I said in the beginning, to protect the public and make sure that you don't end up with gaming in the system. And then I think you have a secondary piece, which is, and I think everybody has already talked about, I think Helen said it well, is where you're able to get the public information to be able to make informed decisions, with the hope that if you set the program up well, you have increased the quality across the board, so that the baseline quality we have within the system is better. And then I think lastly, I think you have measures that may or may not be reported, but we have really good, robust measures that the organizations that are in these programs can use to make themselves better. Because that's really where I'd like the work to be being done. I'd like people spending time on looking at their own organizations and having measures and having robust data sets that, as was noted, aren't just claims measures. They're EHR measures and they're patient experience measures from surveys, but they're also patient-reported outcome measures. And you're able to loop those all together. And I think the things we've been able to do at Geisinger that are the coolest things we're able to do are where we're the payer and where we're the provider, and where we have all that data in one database, because it just gives you such a richer look. And again, to make yourself better, not because you want to publish that or you want to be accountable for that, but that's what we're looking at every day to say, how do we get better for the people we serve?
It's very helpful. Next, we're going to go to another core question. We want to hear about your approaches for measuring performance related to the objectives of total cost of care models. And you've started to dive into this already. So the question is, what are the basic types of performance measures that would be most appropriate for measuring participating organizations' performance relative to the desired characteristics of total cost of care models? Please provide examples of specific performance measures that might be particularly useful. Cheryl, let's start with you.
Okay, so the performance-based total cost of care. I mean, first and foremost, you're going to measure total cost of care. And I know that there's been a desire in the market to try to tamp down on low-value care. But I think, again, it's this tension between macro versus micro. I think it is helpful to have some low-value care measures out in the space, but I don't think that is necessarily what needs to be measured in the context of a total cost of care model. That starts to get into the drill down space. So first and foremost, total cost of care. But I think something that Eric touched on, Helen touched on, this issue around access to care, timeliness of care, and I would also add denials of care. We see in many spaces, particularly in, say, Medicare Advantage, rising concern that people's, the denial rate is quite high. And this is creating a significant burden for physicians in delivering care. And again, there's this tension between trying to reduce the spend, but also we're creating a lot of friction points in the system that may not add value. So I would expand that space. I also think, we need to focus on patient experience. We learn a lot when we talk to patients and learn about their care experiences with how to change the system to be more patient-centered and to deliver care that not only meets some reasonable level of expectation, but can help them manage complex healthcare conditions, because you start to move in the direction, as Eric noted, of building increased trust and connection between patients and providers to co-manage a healthcare condition. And also to learn about what are some of the underlying barriers to a patient being able to succeed, whether they're socioeconomic barriers or other types of barriers. And then lastly, we have to keep doubling down on our focus on equity.
Thank you. John, let's go next to you.
Yeah, I think it's a great question, and that's a great answer. I'd like to come back to I do think the balanced portfolio methodology is the best way to do this. And then I think, actually, to Cheryl's point, in the world we'd like to get to around total cost of care measures is, if we got where we wanted to be, you wouldn't need prior authorization, so that you would, because there is a huge amount of waste in the system to have to ask to be able to do something, but you would create a system so you would have total cost of care at the top, and you would have these fail safes that we talked about to make sure that people weren't gaming the system, and then providers would decide in conversation with their patient about how to treat patients and whether a test or treatment should be done, as opposed to needing to ask someone else, and that the total cost of care model with its quality gates would make sure that was happening all the time. I would like to say, from specific examples, I think looking at some of the kind of classic claims-based measures of utilization per thousand, I think does become important in some of these models. And again, not so much from an accountability standpoint, but to help you manage what you're doing. Because in a perfect world, you'd like to see something where primary care physician visits goes up and specialty visits potentially goes up, but you have decreasing emergency room visits and decreasing inpatient visits per thousand. And, if you're running if you're in that model, you may put programs into place, like say a care management measure or some team-based program, and be able to measure against that and say, does this get the information or does this move those in the direction we want them to move in? So it's one of the things we've seen a lot in many of the care management programs we put into place, and we've seen most specifically recently in Pennsylvania Medicaid, where we've been able to push care to the patient's home and away from the hospital. And in the end, the total cost of care decreases because those hospital-based areas are much more expensive, as we know, than the home-based areas. The last thing just in this piece is, I think it's important too that we look at standardizing the way the data goes into the system, because one of the issues I think we have now is that different provider organizations or providers themselves bill in a different way, or we have different definitions of what's an inpatient procedure or test or treatment versus what's an outpatient. And when you're trying to compare providers to providers, it becomes difficult many times to compare provider A to provider B, or understand what provider A is doing versus provider B, because we have the definitions of how the inputs come in. In many ways, that's the way we bill, and fee for service can be very different from provider to provider.
Thank you so much, John. Eric, what would you add?
I think the one thing I would add, two things, I guess. One is that we do have measures available. They're not perfect. We need better data, again, on control of some very common health threats. So diabetes control of high blood pressure, depression screening, really focusing in on some of those. And maybe this reflects that I sat in a school of public health for many, many years. But when you look at the ability of our public health system to measure those important outcomes, and you say, maybe we ought to re-architect some of what we do in the clinical care delivery system, integrate that better with the public health system, and figure out ways of sampling so that we can understand what's happening with populations on some very, really important markers of health, and that can reduce mortality and morbidity over time. Maternal outcomes is another area that I think we would want to focus. So that's one point, and we'd have to consider reimagining how we would actually deploy that measurement system, because I don't think our current health data exchange infrastructure could support it, but we could design it. The second point, and I think this is just elaborating on John's point, is the mix of services, that understanding the relative spend and total cost of care you can measure. There are challenges, some challenges even around that, but really understanding the mix of the services provided, what's going to primary care, what's going to emergency services, what's going to inpatient services, specialty services, because managing two organizations could have the same total cost of care, and without knowing the outcomes, one of them could be doing a tremendous job and the other could be doing a terrible job in terms of the mix of services offered, with like excessive emergency room use. And we also know, I guess in that context, we have to be careful not to be too optimistic, that it can take 2 to 3 years to see these shifts. So some of the return on investment conversations sort of say, well, what savings can you produce for me next year or within 3 years? And reorienting the system and the mix of services, it's difficult to see that having the kind of impact on these health outcomes that would be within a 2 to 3 year time frame. We really should have a longer time horizon. And I think this is one of the flaws of many of the studies of payment system models in general, is they didn't really allow enough time for the interventions to have their effect.
It's a key point. Helen.
John's right. It's really hard going forth. Much of what has been, what I wanted to say has been said, but I'll just say, I want to emphasize something that goes back to one of the slides from the presentation earlier, which was the issues around unintended consequences. Total cost of care has a number of unintended consequences we already heard about. John's point about gated quality measures, really thinking about only looking at cost. If you've achieved a certain level of quality is really important. Huge concerns about stinting of patient care that I think keep a lot of clinicians up at night about who's not able to get care, and really want to emphasize the point about that Cheryl mentioned about care being denied. I think the idea of stinting, care denials, prior authorization continues to just be a huge burden, minimal relief so far from Congress, but huge burden on clinicians, and really thinking about how we can really think about this. I would hope within the context of a system, are there ways, for example, in a population-based total cost of care model to do something differently internally that might take some of that pressure off of your clinicians who are having to fight that constant battle. Lastly, I just want to make the point that I agree that total cost of care is often at the system level, but I think as you think about the physicians and the other clinicians within your system, thinking about how that relates to them is still really important. It's hard to feel like you're part of that actionable process if in fact it's measured at such a high level that you can't see what you do within that. So kind of breaking that down and then thinking about, are there measures, for example, that look at shared decision making or appropriateness that get us closer towards looking at ways that an individual clinician can play a role in total cost of care. And then want to just emphasize something I put on my slide at the start of this, which is that so much of this really does happen now across clinicians, across settings. And so really thinking about how you fit within a system that might, for example, include post-acute care or home care. And there's just very broader vision of what a system is and what's population-based care, and sort of being able to reflect how your quality fits within that, I think is going to be critical, which is why I think we still need those clinical quality effectiveness measures to allow different specialties to see where they fit within that paradigm. Thanks.
Integration is key. I'm going to ask one other core question and then open it up to the committee and give you a chance. So for the next question, we want to hear about the differences between performance measures for total cost of care models and current performance measures in Medicare value-based payment programs and alternative payment models. So the question is, what are the differences between performance measures needed for population-based total cost of care models and current performance measures used in Medicare value-based payment programs and other alternative payment models? John, let's have you start this one.
Sorry, trying to get to the mute button.
No worries.
Great question. I want to play off of something Eric said. And I think one of the biggest differences is I think if you're truly in total cost of care models, and I agree completely with what Cheryl talked about, is that, moving at a snail's pace into these models isn't helping anybody. It's certainly not helping patients, but I don't think it's helping providers, because it's allowing some of them to keep their heads in the sand, and others that want to move more quickly aren't able to move more quickly. But the measures in total cost of care models really are a long game. And I think right now, somewhat out of necessity, and given where we are, but somewhat out of, quite frankly, I think just being able to get past of the current state and think about a potential future state, we're not able to do long game models. And you have, I think a good example is the Medicare Shared Savings Program, where you have very immediate year-over-year measures, and the process by which those measures are calculated, and sometimes what those measures are, change on an annual basis. And this total cost of care, population-based total cost of care models aren't short game models, they're long game models. They're things that are going to take, 3, 5 or more years to see things happen. So you need measures that recognize that, while also having kind of measures underneath that to be able to make sure people are moving in the right direction. You kind of need leading and lagging indicators, if you will. And I think, that piece is a piece that we really need to think about, because we haven't been able to, I think, in the measurement community, and then I think providers haven't been able to get past. It's a little bit of a, the hamster wheel of over and over with the same measures over and over, and you're thinking, month to month, year to year, as opposed to thinking over time. How are we going to change the health of the population, and I think really a public health way. So to me, that would be the thing I would highlight around what is the big difference.
Thank you. Eric, let's hear from you.
Yeah, I think there are a couple things that are difficult in the current model. The risk adjustment issue is the one that's probably kind of front and center for a lot of folks right now. But I do think we really do need in a population-based total cost of care model, you've got to be able to assess risk of for the population. And to do that well, the Netherlands has a system actually of reallocating funds among the insurers based on the risk of their populations in any given year. so that the notion there is to reduce the risk gaming that can go on of trying to push people out of the model, or bring healthier people into the model, push sicker people out of the model. And so another solution there is to really you can do the cross-sectional approach, or another solution is to be able to follow the people through their journey and understand whether that risk selection is occurring or not between organizations. So if someone disenrolls from the population-based total cost of care, if a person disenrolls and moves to another care setting, whatever that may be, maybe they become homeless, that that the system knows that, the system can account for that. Because right now, there's still, in any risk-based payment model, there's going to be this natural tendency. It's a lot easier to sort of cherry pick or your way to a lower cost model. So I think that I might just sort of emphasize that piece, which we hadn't really talked about much.
Thank you. Helen.
Great, thank you so much. So a few reflections. I think that very much the idea of thinking about how we have measurement at the team level, I think is an important consideration. Those may not look like the same kind of measures we have now. We talked about a lot of these early on, measures that more reflect collaboration, communication, access, communication across specialties, across the system, I think are going to be critical. I also think it's really important that we consider the ways that care has innovated and make sure that the measures go along with that. So, for example, very few of our measures really reflect telehealth. You have a really hard time collecting data on what happens in a telehealth encounter to know whether it was, in fact, high quality. Hospital at home, there are just numerous examples like that where we have to just start thinking about where, as care is innovating, where are the ability to look at those kinds of measurements and make sure that we're appropriately capturing those. I think it's also really important that we think about how we get to some of the outcomes that matter. And I think just in the example here, I think many of these, for example, clinical outcome measures are often reflected in clinical registries, often still very difficult for those measures to be used as part of these processes. One of my favorite expressions is that data travels at the speed of trust. I think there's not a lot of trust right now in the overall system of how those data will be used. Will they be used inappropriately? And how do we create those sort of principles and guardrails that allow us to collectively work together to build on measures already developed for and by clinicians that represent what they consider the highest important outcome measures that they want to be, and will get their benchmark data back on, because it then allows them to reflect on how they can get better. We have numerous examples of that, where not only do you get your benchmarking, but if you don't do well on one of those performance measures, you then get linked to your specialty society's CME to say you didn't do very well on this. How are you going to improve? So I think thinking broadly about how we bring in those registry-based measures, which also get at some of that intrinsic motivation. It's not all about money. Some of this is also the intrinsic motivation of showing people their data compared to their peers. And understanding where they fall short, I think are huge opportunities overall. And again, I think just broadly thinking that many of the quality measures we have now are the same ones we've talked about for years. We've been talking about blood pressure control, diabetes control, et cetera, for years and years. Not that we've done especially better on them. I wish we did, but I think we do need a broader lens on what happens in care. And I think that's a place where particular specialty societies can really help think about how that comes together. Thanks.
Really interesting. Cheryl, what would you add?
I'm going to +1 on what my co-panelists have said. But, as I was thinking about this question, I don't know that the performance measures differ, but I think kind of what gets done with the information and how the information is used. So I thought a little bit about what John was saying about the long game and this issue of knowing you're responsible for a population. Because I think to some extent what's happening in a number of Medicare's performance measurement and value programs is, it's essentially the unit of accountability is the individual hospital, the individual provider, such as in MIPS. And while it's important to measure their performance, it doesn't always feel to me that the information then is used kind of by the organization in a collective sense to drive system improvement. And I think the difference between these population-based total cost of care, accountability type structures is that you start moving away from a siloed approach to something that looks more like an organization can respond and think about how to transform care delivery. It's not clear to me, say in the MIPS program, that physicians are actually looking at their performance and doing much that's any different, particularly since they can self-select the measures, and that provides its own opportunity for gaming. And so I feel like in many ways we have a bifurcated world where you have now roughly 50% of physicians who are employed by health systems or hospital systems. They're part of large organizations that can bring different types of resources and organizational supports to the table to help improve performance. And then you've got, what remains of the small practices. And a lot of those can be in rural environments. Again, what's their ability to be able to respond to a set of metrics, even if they know their performance. So at the end of the day, I don't know that we want sort of different measures for different spaces, but I think the ability of the end user, if you will, to be able to act on them and make change differs tremendously between those environments.
So helpful. So committee members, I want to encourage you to tip your name tent up if you have a question. This is a great opportunity to tap into the expertise of the panelists. And Larry, let's go to you first.
I have so many questions, but my first one's going to be for Cheryl, because you really triggered a thought process with me with your first bullet. And I have to say, I totally agree with you that the core objective is not just to measure performance, but to move health systems towards building a measurement infrastructure on their own. So what does CMS do? What do commercial health plans do with their ACO agreements? How prescriptive do they get inside these organizations to help them build this infrastructure? When an airplane door flies off a 737, the FAA shuts down every 737 till it's been corrected. Whereas when something happens inside of an ACO, be it a Medicare ACO or a commercial ACO, that doesn't happen. So where's the border between building that infrastructure and being overly prescriptive? How would you implement this first bullet you gave us?
I think the government's loath to be over prescriptive, and I think that's always kind of a difficult space for them to operate in. I guess my observation of having watched the world unfold over the past 2 decades is that a lot of the performance measurement that commercial payers and government payers, whether it's Medicaid or Medicare, have put out there, have led health systems to invest in building their own measurement infrastructure. Some are farther along than others. Some have the resources. So, these physicians who are in small practices, have, not been able to build that kind of infrastructure. But, for many of the very large systems, and John, you can speak to what Geisinger is doing, they've built very robust dashboards, and they are measuring not just primary care, but, have delved into the specialty care space. Although I would say, when I've looked at the types of measures that they're measuring internally and incentivizing their providers on, the specialty care space is usually the weakest link. I think to Helen's earlier point, we need to sort of do better in, working with the specialty physicians to build a set of measures and build out that dashboard. Because I think that really is the weakest link that I see right now in what I would call the internal infrastructure and performance dashboard of health systems.
So you would favor incentives or a payment structure to a health system based upon evidence that they're building that infrastructure?
No, I think if you put the performance measures out there, so let's say we had a better set of, specialty measures, I think the systems will build their own internal systems around that because, they are interested in securing the financial incentive, right? And so they need to be able to measure and track that in real time to figure out whether they're going to land and whether they need to pivot, to try to improve their performance. So, my own personal view is I don't think you need to be overly prescriptive. I think you need to send the right directional signals.
Eric, I see your comment.
I couldn't help digging in on this just a little because the health data exchange part of this is so central. And in some ways, we've done ourselves a favor by not getting this right until now. But because the health technologies have advanced to where it could be extremely low cost, and the government is already doing what I think would support what you're describing, which is to create the health data standards, the exchange capabilities, the same thing that powers the rest of the internet, same thing that allows any browser to attach to the internet. That technology can now be brought into healthcare safely with privacy protections and other considerations. And so I think it actually ends up being industry-led rather than the government sort of creating a mandate. It's more creating the conditions under which everyone is doing their work and supporting that. So TEFCA is a trusted exchange framework mechanism that's just getting stood up. There are 6 organizations participating in the TEFCA exchange network. The health data standards are advancing sort of year by year. And a lot of what seemed like it was going to have to be like people investing or individual organizations investing in systems now is looking like just get your system mapped so it can participate in the health data exchange through fast and healthcare interoperability resources and using computing power, which didn't exist. Cloud computing power, those standards all are 5 to 10 years old at most. So there are some technological changes that as we're thinking about this design, we actually want to build toward that. If we try to build for today's system, we're going to miss that boat. And that's driving a lot of our strategy at NCQA as well.
Go ahead, Helen.
And just one very brief comment. It very much builds on what Eric has said as well. I think if you want to build out, if you want to ensure systems all have the right approach to developing their quality reporting systems, internally the dashboards that Larry asked the question about, really important as part of that, you also measure the burden on the clinical teams, because they may say they have a system and it works great, but the burden can all roll down to the clinical teams to in fact be collecting those data, because a lot of what you're talking about, Eric, is wonderful, and it's still the future is coming, and it still is, right? We're still waiting for that to sort of happen at the point of systems being able to use those systems. But I think, being able to pair, for example, measures that look at staff turnover or burnout within a health system to these dashboards would also be appropriate. There's nothing that says it's always about patient care. It can also be about the health of the clinician community, and the cost of turnover are tremendous in health systems. And so really thinking broadly about what you might measure to get that full perspective, I think, is an important consideration.
Excellent. Let's go next to Jen.
Actually, that was a great segue to the question I'm going to ask, which I'll just say might be an unfair one. If you had a magic wand, we've heard in the past around the use of mandatory fill in the blank. So my question is going to be, if you had a magic wand, what things might you make mandatory? And to get you thinking, the things we've heard in the past are multi-payer programs. I heard maybe mandatory empanelment or participation in a program, maybe a mandatory measure set, maybe mandatory removal of prior authorization, maybe mandatory creation of specialty care dashboards, maybe intraoperability, maybe turnover. I want to give you the opportunity to talk about what things you think are so important. Again, not thinking about the fill in the blank regulatory, political, cultural headwinds, but what might be essential mandatory elements for success. I think that was obvious, but
I'll take a first crack at it. I actually think the multi-payer participation arrangements would be valuable because there is so much movement throughout the system of people and providers, and that anything, if anything, some of the mandates already exist around ONC and health data exchange. So the information blocking rule sort of says that you have to make the data about a patient available in electronic form through open API architecture, the same thing that powers the internet, everything else we do, that organizations, electronic health records have to create that capability. And then to the extent that EHR vendors, of which there are still many, but a few dominant ones, implement that, then it becomes easy to participate in that sort of multi-payer environment, because there are also standards for health insurers around the Karen Blue Button standard, which enables that same exchange. So if I had to pick one, I would pick the multi-payer participation, and through the trusted exchange framework or some other mechanism that creates this liquidity of data that would support not just performance measurement, but a whole bunch of other administrative simplification and burden reduction.
Helen, did you want to go next?
Sure, that's a really hard question. And hard to have a simple response to it. I guess I'm a lumper by nature, so I'll say mandatory is anything that increases relevancy and decreases burden. And so I think the ways to do that are multiple, but I think in particular, thinking about ways to get at consistency of measures with decreased burden and higher relevancy, I think it should be, that should just be where we go, because otherwise people are just spinning their wheels, creating measures that don't in fact serve any useful purpose. So eliminate measures that don't add value, focus on the ones that do, and figure out how to do them in a way that's easier and more consistent. And I'm sorry, that wasn't one thing.
And Cheryl, I'm going to go to you next.
I agree. This is a hard question. And I think I'm going to plus one what Eric said in terms of multi-payer participation, not just in terms of trying to align what providers are being asked to pay attention to and devote resources to, but also, the interoperability and exchange of information that can work to coordinate care across settings and enhance care delivery and hopefully potentially reduce low value care. In terms of other mandatory type features, I think what I've struggled with, and I'm sure that this group has as well, is, CMS covers, a very large, complex, array of healthcare settings. And, they're trying to send signals to providers in multiple settings. And I think we historically have done a poor job of identifying good care coordination measures and measuring that across our system. And I think, what I would like to see, and I don't know how you mandate this, but I think we have to, again, rethink sort of the ongoing siloed approach to performance measurement that's happening across all these different settings, not just in Medicare, but, in the commercial space as well. So I know that there's not sort of a hard there, but, I think care coordination is something that needs to be front and center and kind of a core mandate, because people touch so many different settings, especially as they get older, and they need more complex care services.
Thank you. And John, would you like to add?
Sure. Yeah, it is a tough question. And I think the other, was Helen noted, the simplification piece. And I think this notion of getting everybody involved in a multi-payer fashion, I think I would agree with both those. I would say if I had to do something mandatory, it would be a mandatory glide path toward total cost of care models. Because I really think part of why we are where we are is because of the fee-for-service system. And we really have a fee-for-service payment system for services, and we have a fee-for-service pay-per-performance model for quality payment. And I think many times providers look at both of them as widget models, if you will. And I think, we're not making widgets, we're taking care of patients. And I think that those models are much of what's holding us back. I think if we could get a glide path, as I said, to where we're going to go and agree to it, stack hands on it, and say we're not going to go back on that. So I think, the classic go back was we had a glide path with mandatory bundles several years ago, and that stopped, and that, I think, set us back years in how we take care of patients, but also set us back years in those areas about how we were looking at quality assessment, because I just think of what we were doing when we knew those mandatory bundles were going to happen, and talking about from a quality assessment standpoint. And much of that went out the door when those went away. And I just end, I've taken a very different view of the way I look at things, whether when I'm wearing a health plan hat, when I'm have a total cost of care responsibility for a population, versus maybe when I was a chief quality officer and was looking at a program, and not to pick on programs, but a value-based purchasing for the hospitals. And it was a very transactional look at the value-based care program, whereas the total cost of care program on the health plan side is really looking at, how do I get what's the quality I want for my members, but what subsets of measures do I need to be able to drive that quality, and to get people, and I think Helen said it great earlier, to get people to trust and work together for a common goal.
Great. I'm going to add a follow-on question that was submitted, so it taps into what you've already been talking about. So this question focuses on measuring aspects of system transformation, for example, care coordination and team-based care. So what should be the mixture of quality, outcome, patient experience, process, and utilization or cost measures for actually measuring system transformation, or should it be the same? That's the question submitted. Who would like to start?
I'm feeling bold today. I'll go. I do think it probably switches the focus more toward the outcomes and equity and other system level kind of outcomes. And the reason I worry about that is there's also a lot of care model innovation going on right now. Some of it won't persist, but there are companies getting into lifestyle coaching and management support that are still operating independently of the healthcare system in some ways. They don't integrate well. When they try to integrate, what they can do is provide a PDF to people that they can bring to their doctor, which isn't kind of a workable, it's an interim solution, but it's not what we'd like to see ideally. But I think Helen made the point earlier about the telemedicine and the virtual care models. In behavioral health, it's almost a mandatory, sort of, not mandatory, but it's a clear path that we have to go toward to meet the needs of the population. And then the innovation around who's providing the care, community health workers, peer counselors. If we over-index on process measures, we kind of start to impede that innovation, which could create a better team-based care environment, better care coordination, if we enable it. So we don't want to sort of get in the way of it by over-engineering process measures.
That's great. Helen?
Yeah.
Totally agree with what Eric pointed out, particularly around equity and thinking about care coordination as measures are really important, obviously, at the total cost of care level for system transformation. I'll just emphasize what I said earlier. I also think, a critical part of health system transformation is actually ensuring that we take good care of our clinicians. So let's not forget about that and the burden that this all places on them, and figure out how to do this in a way that both is not a huge burden to them, but at the same time provide information back to them measurement-wise that sort of allows them to build on their intrinsic motivation to take better care of patients because it's relevant and actionable. Thanks.
And John, it looked like you were trying to comment. Am I reading you?
I think it's a great question. To me, it's the same as other things, but what I would say is that in the total cost of care model, I don't think that you are necessarily going to you're going to report on that transformation if you choose to report on it because you're reporting to research or you're reporting to make the world a better place. But there shouldn't be accountability measures in my mind that get reported for those transformations. Now, I think, using the example of what we've done at Geisinger at Home, which is a at-home model where we take care of the sickest of the sick at home, we do that because it makes sense in a total cost of care model, and we probably wouldn't have done that if it was a fee-for-service based model, because it wouldn't have made sense just to bill per service for that. But if you're in a total cost of care model, it makes complete sense because it does a better job taking care of the patient and thus decrease the total cost of care. But we measure all kinds of things to see how that model is working to make sure that it is actually decreasing total cost of care, because you could get in the trap of providing a very expensive care set and it actually costs more than the care, and you essentially end up wasting that resource. And the other piece in the healthcare system, we have finite resources, whether it's physician resources or nursing resources or all other pieces of the puzzle for resources. So we need to measure to make sure that for each time we're providing that care, we're actually doing something. And I think lastly, I would say you need to look at equity and you need to look at the patient's experience with it, because in that program, for example, if they're going to let you into their home, they need to have a great experience, or the next person, they're not going to let you into their home and you're not going to be able to get them the care they need. So I do think it's that broad portfolio of measures, but it's not mandated by someone else. That just the model, because you're now in a total cost of care model, will end up creating innovation around the measurement and how you look at those programs.
Thank you. We have only 5 minutes left. Walter, is it a lightning round question we can go to? Yes, it is.
I'll try and make it quick. Just wanted to thank our panelists for a really rich and informative discussion. I've learned a lot. I wanted to just maybe end on this concept of a balanced portfolio of measures that John brought up. I think all of our panelists, it's probably safe to say, in terms of measures under total cost of care models, first among equals would be the total cost of care. We also talked a bit about stinting, rationing, patient sensitivity to that. What other kind of guardrail measures or balanced portfolio measures would our panelists include in kind of the top level, most important measures to achieve that balanced portfolio of measures?
Eric?
I guess I would go back to the safety reliability conversation, because I think in the hospital setting, we've come up with better measures of safety and reliability, but I don't think we've done that as well in the broader ambulatory setting, population, care at home. Care at home actually is an interesting example, because anyone who tries to operate a hospital at home program is going to definitely build in those safety measures as part of the endeavor. So it really does go back to Dr. Bulger's point about you'll actually build the measures you need, and safety and reliability would be one I would add. I also want to second Helen's comment about the staff and workforce, and making sure that they're feeling that the care is safe and reliable.
Helen?
Just building on what Eric said, first thing I wrote down was patient harm. So I think there's like a little mind meld happening here on the side of the table. I think patient harm has got to be there. We've got to really always keep in mind, as much as we're saying we're improving outcomes, we still have significant safety issues in this nation. And so thinking about issues, a balanced portfolio should include measures around harm. I think it should include measures around equity, coordination. And I think since so much of the discussion is about thinking about, for example, a specialty portfolio, for example, I think getting at measures of appropriateness, both in terms of eliminating low value care, but at the same time, ensuring high value care is provided, and then we're not having stinting and we're not having difficulties with access because of prior authorization health plans. Thanks.
And Cheryl.
Yeah, so I would plus one what's been said. I think it's particularly important to look at access issues, whether that's in the form of denials or just, wait times. I've had a recent personal experience of being referred to a specialist and not being able to make an appointment for a year. And I have very good insurance and, so there are a lot of complexities in play in the marketplace right now. And, one of the types of measures, when you think about care transformation, I think Eric touched on this earlier about, where are the dollars going and is there sufficient, revenue going toward primary care? And I think, and Helen touched on the burnout issue. I think that, we have greater demand than we have providers to provide the set of services. And so I'm, been noodling on, do we start to introduce some other structural type measures, looking at, the physician supply or the clinician supply that's available to care for patients within the system. And, you can look, and I've started to do some of this work on the Medicaid side at, the adequacy of provider networks. And oftentimes, patients who most need care are living in what I would call ambulatory care deserts. And so I think this whole issue around access is going to be paramount within the context of total cost of care models.
And John, would you like to add in as well?
Sure. I think, and I agree with all of that. I think it's all well laid out. I think I just add at the end here that I think some measurement of churn. So some understanding of the ins and outs within the covered lives or the panels or however you want to look at it, that takes into account obviously death and other things that would not necessarily be in control. But the notion of are you creating a system that you're trying to game by moving people in and out and trying to cherry pick, or have you created a system that patients can't get access, so they have to move to someone else? But I think some measure of churn would be important in these programs.
I want to thank each of our panelists for very valuable, rich dialogue. We've covered a lot of ground today. We want to encourage you. You're welcome to stay for the rest of the day. And we want to thank you so much for your valuable time. It's been really helped to inform the dialogue. At this time, we're going to take a break and we will resume again at 1 p.m. Eastern. So please join us then. We have a great lineup of guests for our first listening session of the day. Thank you for joining us.
Produced by the U.S. Department of Health and Human Services.